Good day, friends, and a warm welcome to this edition of 4D. It's season 2, episode 33. And as you all know, 4D means detailed discussion and dialogue in diabetes and in Indian diabetes. Now, we speak of evidence based care, but along with evidence, you also need experience, you need expertise, and you need eminence as well. And these are all the things that our speaker brings today. Not only evidence based learning, but also eminence, experience, and expertise. And I'd like to add another E, which is empathy. An excellent human being, someone whom I look up to. A warm welcome to Dr. Parag Shah. Warm welcome,
Thank you.
sir.
Thank you.
Dr. Parag is one of the senior most endocrinologists in the country. And actually, when you look at people who've been able to go into private practice, he is actually one of the most senior, with a capital T, one of the most senior endocrinologists in the country. He has been running the Gujarat Diabetes Center now for more than 2.5 decades. He has been instrumental in expanding and enhancing the space of endocrinology and diabetes in Western India and across India. And he has also organized for us many years ago the Endocrine Society of India National Conference. Warm welcome, sir.
Thank you. Thank you for a kind introduction.
Sir, we've been working in endocrinology now for more than 2.5 decades, you and I, and things have changed. The definition of endocrine disease, the definition of metabolic disease seems to have changed. So earlier we used to focus on glucose alone, maybe glucose, thyroid, hypoglycemia. But now, why are we speaking more and more often about cardiovascular disease? What do the vessels, what do the heart, what do these have to do with endocrine disease and with metabolic disease, with diabetes?
So I think last 3 decades since I am into endocrinology, right from my training to my practice, the focus has shifted from glucocentric approach to the metabolic health. And we all used to know that diabetes is the disease which is responsible for the cardiovascular or microvascular complications. As more and more data are generated, the prevalence of the atherosclerotic and the microvascular diseases going hand to hand along with the dysglycemia right from the pre-diabetes days. So ultimately, we all know that diabetic patients sooner or later are likely to get cardiovascular disease, and the most common cause of mortality among the diabetic populations is the atherosclerotic cardiovascular disease or the congestive heart failure related issues. Even the diabetic kidney disease patients also, most of them die because of the cardiovascular disease, and only few actually lucky one survive to go for the renal replacement therapy. So we all know that diabetes and the cardiovascular disease goes hands to hand. Are they partners in crime? I would say it's like a Jay and Viru in Sholay. Okay, if you don't take care of them, if they are on the wrong path, they may do the devastating thing. But if they are into the better part, they can prevent actually. I always tell to my newly detected type 2 diabetic patients that there is no better enemy than diabetes and there is no better friend than diabetes. Because diabetic patients, being a diabetic, come to medical attention, medical supervision, surveillance for the hypertension, dyslipidemia, re-emphasis of lifestyle modification, re-emphasis to get all the things under target. And now with the medications, we can prevent cardiovascular, renal, and the metabolic complication associated with the dysglycemia or metabolic syndrome. So, diabetic patients, if they take care of their metabolic health right from day one, I would say they would live longer and a better life than a patients who are not having a diabetes, because we got an excellent understanding about the pathophysiology. We got an excellent tools to detect the early micro or the microvascular complication, and we got excellent agents to reverse and to prevent the further deterioration of the cardiovascular disease. So they are like a Jay and Viru. Bad sides, they can do the worst. If they are on the good side, they can put the gabbar at rest. So that is what I feel about the diabetes and the cardiovascular disease. Whether they are partners, yes, or they can be synchronized approach, can prevent lots of devastating morbidity as well as the mortality is concerned.
What you're saying, sir, is very nice. First of all, we know the outcome or the trajectory if we don't do anything. That's the trajectory. But now we have the tools to measure, to monitor, to screen, to suspect, and all of these in a timely manner. and third, we have the tools or techniques to correct the trajectory. And I think that is a very nice thing. Instead of always speaking about ominous octet or about side effects or complications, we can speak about how we can change the trajectory in an optimistic manner. So, sir, would you like to share more insight regarding this? Your topic is diabetes and cardiovascular disease, partners in crime. And like you said, you will also be talking about partners in good health, how we can convert this obstacle into an opportunity.
If I go by the few slides just to set the ball rolling, we all know the prevalence of diabetes is increasing, and unfortunately, the type 2 diabetic are occurring at a younger and younger age group. And now it's not uncommon. Dr. Sanjay would agree. We have been practicing more than 2 decades, both of us. We are seeing younger type 2 diabetes coming to us quite frequently, which was previously unheard of. When we started our endocrinology, anybody below 35 years of age detected diabetes, we always used to think as secondary causes or think of the type 1 diabetes or a LADA. But now we see lots of type 2 occurring at a younger and younger age. The number is increasing, and along with that, the pre-diabetic populations also are increasing. Central obesity is increasing, which is the actually the culprit of the all the metabolic disarrangement. We all know that we all are a thin fat Indians with the insulin resistance practically occurring at an early childhood, translating into early cardiovascular disease, early hypertension, dyslipidemia. If we start screening in the younger children, we'll find lots of high LDL and low HDL. There's lots of type 2 diabetic when we do the screening for the dyslipidemia at the age of say 18 or 20. Lots of them have a LDL of 160, 180, and HDL is hardly 40. So we got a lots of so-called thin fat Indians. And of course, the obesity is increasing, central obesity is increasing, stress levels are increasing, lifestyle have become from the worst to worst. In schools, the playgrounds, the new schools hardly have a playgrounds. There are all the classes, tuition classes, schools going on. Nobody goes to the school on a bicycle. We used to go to college in the bicycles. Now practically hardly anybody goes to the school even at the bicycle. They are going in a van or a car, and lots of deaths are occurring because of the diabetes, and millions of people are suffering, millions are undiagnosed. So there is a huge burden of diabetes in our country, and we all know the prevalence of the cardiovascular disease is quite high. Two-thirds of the diabetic patients die of the cardiovascular disease, of which most common is the atherosclerotic cardiovascular disease. And mortality and occurrence of the coronary event among the Asian Indian populations compared to Caucasian population is not only at a younger age. We say lots of multi-vessel disease more common among the Asian Indian populations compared to single vessel disease. We see more diffuse diseases requiring multiple stenting or the CABG, and even mortality is higher among the Asian Indian populations, probably because of the underlying insulin resistance and bad lifestyles, poor exercise, and sudden change in the dietary habits has put us at a higher risk. Go by the Fleming et al. Study, the higher the number of the risk factor, more would be the risk of the cardiovascular disease. Like BMI of more than 27 is the Framingham study. For us, more than 25 is obesity, 22 to 25 is overweight, smoking, dyslipidemia, diabetic hypertension. So if the diabetic patients with a central obesity, with a dyslipidemia in India, specifically very low HDL, with a even LDL of 100 is actually high when the HDL is 40 or 45. Hypertension, dyslipidemia altogether puts the odds ratio is almost 5 times higher than a single risk factor. There are lots of risk factor for CVD in a diabetic populations. We all know the underlying culprit is the central visceral obesity, which leads to the inflammation, insulin resistance, leading to the hyperinsulinemia, insulin resistance at the skeletal muscles and the adipocytes, leading to hyperglycemia, increased free fatty acids levels, increased glycated end products, more thrombotic parameters, low HDL with a high LDL, and most of us has a high small dense LDL. Those who have low HDL with high triglyceride, which is a typical Indian dyslipidemic triad, where we see slightly elevated total LDL, low HDL and high triglyceride, ultimately translating into more small dense LDL, which is a more atherogenic LDL. Lots of inflammatory markers are triggered because of the central obesity, leading to the insulin resistance, and there is a dyslipidemia. Lots of free fatty acids are coming from the liver, and hypertension, dyslipidemia, and all these thrombotic and inflammatory markers puts the diabetic patients at a higher risk of atherosclerotic cardiovascular diseases. So all this pathophysiology actually increases the oxidative states, leads to low-grade inflammation, endothelial dysfunctions, ultimately translating into the atherosclerotic disease. Previously, we used to segregate micro and macrovascular complications, but underlying pathophysiology is the endothelial dysfunctions, which is contributed for micro as well as the macrovascular complications. So how can we prevent the CVD in a diabetic populations? First is to identify the risk factors at an early age. So CVD can be prevented or delayed by diagnosing hyper or dysglycemia, hypertension, dyslipidemia, central obesity, stress, tobacco abuse, unhealthy lifestyles, decreased physical activity. So all this together puts the patient at higher risk of the CVD. So we have to try to correct at least all the abnormalities, and focus should be on the lifestyle modification. Tobacco people consider as a culprit only for the carcinoma. So I tell all my patients that tobacco is bad as far as the carcinoma risk is concerned, but fortunately or unfortunately, it is 1 in 5,000 people taking tobacco develops cancer, and lots of non tobacco users develop cancer. So common public considers that cancer can occur if it is there in our destiny. But I tell that 80% of the smoker or a tobacco users with a any of the metabolic syndrome are having a 80% chance of having a atherosclerotic diseases. So I try to concentrate more time on my counseling about the cessation of the tobacco use, trying to bring down the central obesity by healthy lifestyles and exercising at least 30 to 40 minutes a day, at least 5 to 6 days in a week. Now people have the smartwatch and the apps. People will say, I have completed 5,000 steps, but that is not the actual physical exercise. It is a physical activity. So people have to differentiate between physical activity and the physical exercise. Any uninterrupted exercise where you are trying to achieve your target heart rate for at least 30 minutes is your physical exercise. So primary prevention involves the prevention of the CVD by controlling all the risk factor as early as possible, and secondary is of course if somebody who already had a established CVD. So therapeutic strategies for diabetics, I think the metformin monotherapy days are gone actually. I have stopped using metformin as a monotherapy since the DP4 inhibitor has come in our armamentarium, which does not produce hypoglycemia or weight gain. And now with the lots of studies showing the early combination therapy puts the beta cell at rest. It leads to the good glycemic, good metabolic memory, leading to less chance of the micro and macrovascular complication. UKPDS follow-up data, STENO2 follow-up data, DCCT follow-up data all have suggested that early good glycemic control puts a environment which is non-atherogenic environment right from the beginning. It preserves the beta cell functions, and the need of a titration of the medications are significantly reduced. And now we get agents like a DP4 inhibitor in the form of CETAS, Hexal, Lina, and the alogliptin has a neutral as far as the weight is concerned, no risk of hypoglycemia. At least the Lina and the Sita are the cardiovascular neutral. We got a Cana, DEPA, and the EMPA showing excellent cardio renal metabolic benefit. GLP receptor agonist, there is a once a day or once a week. They have excellent beta cell preservative functions. It significantly reduces the body weight. It reduces the chances of the atherosclerotic cardiovascular diseases significantly. If you combine SGLT2 inhibitor and DP4 inhibitor, both are working in a synergistic manner, taking care of the 6 out of 8 omnious octet pathophysiology, leading to significant reduction into the blood sugar without producing hypoglycemia. weight loss effect of the SGLT2 inhibitor is not negated by the DP4 inhibitor. It leads to some reduction in the systolic blood pressure, and SGLT2 inhibitor has an excellent cardio-renal metabolic benefits also. So if you see the declare team is 58 trial data with the dapagliflozin in a multiple risk factor populations, there is a significant reduction into the composite endpoint of the cardiovascular mortality as well as hospitalization for heart failure, and the 3 pain mouse also was reduced, though it did not reach the statistical significance. So this was just a overview about what has changed in our understanding about the diabetes and diabetic related complication, how newer pharmacological agents can help to prevent the cardiovascular morbidity and mortality associated with the metabolic syndrome or the type 2 diabetes.
Thank you, sir. Great discussion. And you've put everything in perspective for us. Sir, a lot of questions coming from across India. Uh, One question is, sir, what kind of medicines were we giving earlier? You've been in practice for 3 decades now. What was the mainstay of treatment at that time? And what are the limitations and the strengths of those treatments?
See, I think both of us have passed through the era where we had only sulfonylureas and metformin and insulin. Only three agents were available with us. And the biggest hurdle was about the hypoglycemia, because as soon as metformin, we all know, is an excellent agent, but per se alone is a very weak anti-diabetic agent. So it needs the support of some other agents. And we all know that we got a insulin resistance as well as the insulin deficiency. So sulfonylureas definitely takes care of the insulin deficiency till beta cells are having a secretory capacity. But as soon as you start to uptitrate the dose of the sulfonylurea, the biggest hurdle was the hypoglycemia. Even the mild hypoglycemia is very frightening. People are less afraid about blood sugar of 300 than the blood sugar of 70, even if they are symptomatic. Every day, I think you and me try to counsel the patient that 85 is a normal sugar. Don't down titrate the dose. But because there's a relative hypoglycemia, people are so much afraid. So naturally, even mild hypoglycemia is very troublesome for the patients because it affects their quality of life. And we all know that hypoglycemic unawareness and the severe hypoglycemia is one of the most uh, uh,
Some
devastating experience for the patients as well as their family members, or the even the nearby persons who are not the family members, because the situation is such as somebody has a severe neuroglycopenic symptoms, somebody suddenly becoming unconscious, chances of accidents are there. So these were the challenges, and then starting on a insulin even today is a challenge. So previously, when we used to have not had such a good insulin syringes, pens were not there when we started our practice. So people had a fear of the injections, and it was really painful injections. We had a long acting, we have got ultra lente, and we had a NPH insulins. So chances of hypoglycemias were significantly high. So there were lots of issues when the till at least 1.5 or 2 decades ago. Then the pioglitazone and acarbose came into picture, and then were the first, after the metformin, the first non-hypoglycemic agents available with us, and then actually change our way we started our practice. The need of sulfonylurea started decreasing when the even pioglitazone and acarbose came into picture. We used to give a smaller dose compared to what used to give the larger dose previously when we did not have any other options.
Sir, is there a change also in the way patients behave? Like maybe 2, 3 decades ago, patients would just say, "Aap meri sugar theek kar do, fix my sugar," and now they ask you specifically, "Sir, this medicine safe for my heart? Is it safe for my kidney?" And in Gujarat, do they also ask you, "Sir, is it safe for my left kidney and for my right kidney both?"
See, everybody unfortunately has a fear about the anti-diabetic medications leading to the medication per se damaging the heart, kidney, and the liver. So that is the first concern, and that is the wrong concept. Actually, we don't want to discuss it why it has occurred. But people consider that allopathy medications have lots of side effects, and will long term taking these medications will harm my kidney and heart. So we first ensure that no drugs per se would damage your heart or a kidney or a liver. and it is actually studied in a such a way that it would not harm at least. Now we always say that when we start the drugs like SGLT2 inhibitor or GLP-1 receptor agonist, we always tell that, okay, this is the drug which, if somebody has a heart failure or a kidney failure because of some other reason other than diabetes, this is now the drug of choice to prevent the further deterioration of the heart failure or the kidney disease. And now with lots of literature also being available, net is available with them, so we tell them to go to the right site. We tell them the link if somebody is really uh, very net savvy, that okay, you go to this sites, because sometimes people search but they don't go to the proper site. So we tell them that all the guidelines, all the recommendations, you go through anywhere in the world, these are all the safe drugs actually. And so now I tell my patient, why I need two medications, why I need three medications. I tell that I want you to live till 85 years of age without any complications, with a good quality of life. So if you are taking this medication, if you prevent heart failure or a kidney failure or infarct, then why not to take one medications regularly rather than, सर शुगर तो ठीक हो गया है, अभी दवाई कम कर दो ना, सर शुगर तो ठीक हो गया है, बीपी तो ठीक हो गया, अभी बीपी की दवाई तो कम कर दो ना। तो मैं बोलता हूँ पेशेंट्स को कि खाना अच्छा बन गया है 10 दिन तक, तो 11वें दिन क्या करते हैं, मसाला कम डालते हैं कि उतना ही डालते हैं, चलो परफेक्ट खाना बन गया है तो अभी मसाला कम डालो। आई ऑलवेज टेल कि ओके, बिकॉज एंड आई टेल ऑलवेज डिपेंडिंग अपॉन द पीपल विल ऑलवेज say, सर ये दवाई लाइफ टाइम रहेगी, बाद में बंद हो जाएगी, कम हो जाएगी। आई ऑलवेज टेल इट डिपेंडिंग अपॉन द सिचुएशन आई विल डिसाइड। When I go to buy a shirt, I decide which size shirt I will buy. If today I need a 40 size shirt, I will buy 40 size shoe. After 1 year, suppose I need a 38 size shoes, shirt, I will buy 38 or 42. So I tell them we always do to try to give the maximum possible protective medications suiting into your metabolic health and the risk factors. And if I feel that by decreasing the dosage, you still are going to have a good quality of life without complication, I will decrease. Then most of the people would understand and try to continue, because nobody likes to take medications. That's true for us also. Nobody would like to take medications, but when we explain them why we are giving, what is the purpose, it is not for the numbers alone, like statins. LDL has come down to 70, और अभी ये बंद कर देते हैं दवाई, अभी तो नॉर्मल हो गया है, तो we always tell that this is for prevention of your heart attack. It is not for the lipids. When we give the SGLT2, we tell them that this is not only to bring down their HbA1c, it is to protect your kidney, heart, and metabolic health together. So then probably most of the people will try to continue.
That is nice way of explaining, sir. This is actually very helpful what you are saying. And you try to create analogies from day-to-day life, from routine life. Don't talk about anything like rocket science or PhD science. Explain in simple words. Like you have given examples from the kitchen. You have given examples from clothes, from shopping. So these day-to-day activities we can use to explain to them the importance of using such medication. So, sir, you have mentioned earlier hypoglycemia was a big issue. Now it is not big because we have better drugs. We are also able to tell our patient not only are these drugs safe for your heart and your left kidney and right kidney, they are also beneficial. We can actually arrest the trajectory of worsening of disease. So we can prevent your kidney and heart from becoming worse. Actually, we can help improve the health of your heart and kidney and other organs.
Absolutely.
So, sir, now so many drugs have to be given for this. So, fixed dose combinations, for those who are not aware, actually, the capital, the first place where fixed dose combinations were created in the world, that was India, and specifically Gujarat state. All the factories in Ahmedabad. Some of those drugs are not available now, like for example, fenformin and chlorpropamide. But this was the first FDC in the diabetes space. Another FDC that we have been using almost since independence is iron folic acid. So India is a leader, trailblazer across the world in these. So, sir, role of fixed dose combinations. Let us say I want to give metformin separately, sitagliptin separately, and dapagliflozin separately, all for their glycemic, extra glycemic benefits. How will the patient react if I do that, and what is the easy way out?
See, See, globally, the compliance is directly proportional to the number of tablets, inversely proportionate. The more the number of tablets, less likelihood to be having a compliant. Because number one, people don't like to take too many tablets. Number two, in day-to-day lifestyle, taking some medications before, some medications after, some afternoon, some morning, some evening is always a difficult. So chances of having a good adherence is significantly less if you are giving 2 or 3 tablets separately, compared that with the fixed dose combination. Second, about the cost also is significantly less if you combine 2 or 3 drugs in a one pill compared to giving it as a separately. The disadvantage of combination drug sometimes is because you want to give a separate dose with the separate molecules in a separate tablets. So now with the newer agents where the hypoglycemia is not a concern, like glimepiride with metformin, sometimes you don't want to decrease the dose of metformin, but you want to decrease the dose of glimepiride because of the hypoglycemia. Then the challenge occurs. But now with this non-hypoglycemic drug combination, whether it's a sita-dapa metformin or sita-metformin and pioglitazone also in some patients, the chances of adjustment difficulty is not there. So once you are giving the full dose, and you don't really need to up titrate or down titrate the dose when we are giving in a combination therapy. So that is actually increase the usage of combination therapy by all of us. So apart from cost effectiveness, compliance, now it is very rational to combine the therapeutic dose of 3 drugs in one pills or 2 drugs in a one pill to give them, which patient needs to be continued for a long period of time in at least 90-95% of the patients.
Thank you for this tip as well. So when we use fixed dose combinations, we are able to reduce the pill burden. Patient feels very happy. You may be given triple oral therapy like metformin, dapa, sita, but patient is not bothered so much about that. Patient, from a person-centered point of view, patient will say, Doctor, Sahab, do I have to take one tablet or 10 or 20 in the day? And how many times do I have to take? And also flexibility. If there is a tablet which I have to take 30 minutes before breakfast in a with a big glass of water, and the glass should be a copper glass. If you keep on making things more difficult for the patient will stop adhering to therapy. So something simple. So sir, let us say we are giving dapa, sita and metformin in combination. Can we give in a copper jug or a steel jug, or it can be any kind of water the patient can take with?
Yeah, people always consider copper glass water is better for their health. So they may continue, but you can give it anyway, before meals, after meals. It does not really going to matter.
So we have this concept. I would like Dr. Parag's opinion on this before we conclude. We talk of placebo. Placebo means something that pleases you. We also talk of nocebo, that means no effect. In placebo, usually when you look at the literature, you assume that the placebo is an inert substance, but it has to be a capsule or a tablet or an injection or maybe a sham procedure. Many kind of placebos we use from a social perspective, and we use the word socio-sebo or sociable. Let us take examples and let us ask Dr. Shah for his experience gained over the past 3 decades. For example, someone might come and you might give a comfort food, a comfort spice, or a comfort beverage. So maybe patient says, Doctor, can I take fenugreek water? So the answer is yes, you can take if it comforts you. But if you are taking thyroxine or you are taking semaglutide tablet, then don't take along with that, please. Keep 4 hours earlier or
Yeah.
later. That is an example of a social or a comfort beverage. Another comfort beverage from North India would be turmeric milk, haldi wala doodh.
Mhm.
A comfort spice may be elaichi or cardamom. So somebody says, I cannot resist tea and I have to put 2 cubes of sugar in my tea. And I have also heard that sugar free is dangerous. So you say it's not, but why don't you try double elaichi? Why don't you put two pieces of cardamom? Or maybe you put cinnamon powder, dalchini ka powder. So that's a comfort spice which will help the tea become tasty. Comfort food maybe if you're hungry, you just take cucumber or you take roasted gram. So it helps improve the satiety. Comfort procedure would be something that I recently learned. Dr. Parag, in English, it sounds so nice. So the comfort procedure is glossopalatal procedure, maneuver. Glossopalatal maneuver is you take your tongue, the tip of your tongue, and you press your palate with it very hard. So let's all try. Now, when you're doing that, so I can't do it now because when you do that, when I press my palate with the tip of my tongue, I cannot speak. If I continue, I will not be able to breathe also. And it's a very nice way of meditation. It's a very nice way of reaching higher level of spirituality. Uh, For some people, this is the beauty of India, this is the beauty of person centered care. The word glossopalatal maneuver, if you have to know the English spelling of maneuver also, that will be very nice. For other people, this actually comes from Maitri Upanishad. So, Maitri Upanishad, book 6, verse 20. That is what they say. If you want to reach Brahman, this is the procedure that you do. But some people may not like it. Some may, so it's up to others. So, sir, some
Individual.
comfort examples you have given. How can we improve the efficacy of DAPA Sita metformin combination with any other thing, any socio-SIBOs, any socio-IBOs that you practice, sir? We would like to learn from you.
No, actually, along with the scientifically proven medications, we always ask them to do some meditation to reduce their stress, do regular exercise, and uh, change the lifestyle of the dietary habits of the family. You can't isolate one person in a family. सर मेरा तो अलग खाना बनता है, मैं तो ये खाती नहीं हूँ, बाकी सब खाते हैं। सर मैं तो नहीं खाता हूँ, मैं तो नहीं खाती हूँ। I always tell that the separate food is cooked only when somebody has a enteric fever or a jaundice. Otherwise, all food is cooked same. So you have to change the understanding of the whole family to make the. I always say that there is no diabetic diet. Sorry, diabetic diet. What is a diabetic diet? It's nothing like a diabetic diet. It's a healthy diet for everyone. So I always say that whatever we tell to diabetic patient is good for your small kids also. It's good for your elderly persons also living in your family or a spouse also. So we always tell there's nothing like a diabetic food. What I can eat, what and healthy individual should eat, diabetic should eat, or what the diabetic should eat, healthy individual also should eat the same thing to avoid the development of the future metabolic syndromes or atherosclerotic process. So I always tell them that along with the medication, healthy lifestyle, cessation of the tobacco, relaxation by some meditation should help. And I think that is what actually makes them understand कि हाँ खाली दवाई के साथ साथ ये भी करना पड़ेगा.
Uh, that is a real wisdom coming from an expert. So, apart from the medicine, you counseling. See how many times sir has focused on the word counseling and relaxation, meditation, and whatever suits the patient. To someone, you may speak of
Exactly.
religiosity, religion. To another person, you may speak of spirituality. Uh, and yet another person may like the word meditation, or like we said, glossopalatal maneuver. I find it very difficult, Dr. Parag, to remember this English.
Yes, yes.
but, but I hope that everybody has enjoyed our learning from Dr. Parag Shah. I myself have enjoyed it a lot. Like I said, I look up to him as a very respected senior, someone who has actually changed the way that we practice endocrinology and diabetes care across India. Thank you so much, Dr. Parag.
Hey, Dr. Sanjay, you are a flag holder of endocrinology for India, for all of us. We always feel very proud of you. Yes. So you are a face of endocrinology of India. So we always feel very proud that we got a colleague like you in our endocrinology fraternity.
Thank you, sir. Your eyes are kind. And with this, I would like to thank everyone who is logged in for this episode of 4D. Season 2 is continuing, and don't forget to log in again next week. We have experts coming from across India, and all of them share their insights, their inspiration. Let's work together to make India a happier and a healthier nation. And best wishes, three cheers for our boys who won the bronze medal today at Tokyo.
Yes, yes,
Jai
yes.
Hind.